Welcome to our podcast, The Better You Are, The Better You Are. Whether it is physically, mentally, or spiritually, when you know better, you can do better. And when you do better, you'll be better. On this podcast, we share knowledge, expertise, opinions, and experiences. All things that can help you to change the game. By the time we're done, it's hard for you not to be encouraged. So join us.
Okay, so let's start at the beginning.
The better you are.
Pregnant. And certainly during pregnancy, one of the things that we watch for all the time is preeclampsia. It's something that only comes with pregnancy. It can be associated with severe complications. But we know that women with underlying health conditions such as hypertension or diabetes are more at risk. And I'd like to ask Dr. Dawson to just tell us, some concerns about hypertension. How is it defined, and why is it important to manage it? And we'll think of some other questions as we go along.
All right. So I think the biggest thing is if your blood pressure is 140 over 90, 3 times, essentially, you are hypertensive. And so what I try to do, especially with women who are childbearing age, which is anyone who still has a menstrual period, point blank, is we discuss, do you want to have a child? And if you don't, what are we doing to prevent that from happening? And we have to control your blood pressure. And so the first thing is if they're like, I don't want to have children, I have an IUD, then we talk about, especially if they're diabetic, we'll talk about an ACE or an ARB because that's going to protect their kidneys.
What's an ACE?
So an ACE is a particular type of hypertensive medications that actually will protect your kidneys if you're hypertensive and diabetic. And so we use those a lot. And so people hear a lot about lisinopril, which we don't tend to use in African-American populations because we are more likely to have the side effects of lisinopril. However, there are other ACE inhibitors as well as ARBs that we will use to protect your kidneys and to get your blood pressure down. So it's a particular type of blood pressure medications. I think the biggest thing that I tell my patients when they hear the word lisinopril, they're like, I don't want to take that. I've heard all bad things. And I was like, that's not normally the one I would start you with. There are other ones we can try. And so we want to control your blood pressure, but the ACE and an ARB is contraindicated in pregnancy because it can cause complications to your baby. And so those are ones we will not use if you are thinking about having a baby.
So that's why it's important to see a doctor.
That's why it's important.
And talk to them, build a relationship, let them know what you're planning in life, and get on a good drug before you ever get pregnant.
Absolutely. And so my biggest thing is to talk to my patients, find out what your decisions are going to be so we can make the best decision for you. So my biggest thing is saying, hey, we've got to control your blood pressure if you want to get pregnant or if you're trying to get pregnant before you get pregnant. Because what we don't want to happen is, for one, you have hypertension during pregnancy that they are unable to control, but prevent complications while you are pregnant or having preeclampsia later on.
Let's say somebody doesn't even care about getting pregnant. Why is it important to control blood pressure? Why is it important to see a doctor, get your blood pressure checked, and manage your blood pressure?
Big thing, I always tell my patients, blood pressure is a silent killer. You will not be able to get through life with your blood pressure being high without having some complications later on. And so we'll talk about the easy complications or the ones we can kind of control. So, hey, you have elevated blood pressure and you have a TIA. Well, that's reversible, essentially. Your TIA, you're not going to have long-term complications to that. However, what if you have a stroke? And then you're not able to walk or to talk or to communicate. And so the biggest thing is you won't necessarily feel when your blood pressure is high, 140 over 90, 160 over 100. But say you get in a car accident and your blood pressure has been running 160 over 100. Guess what it's going to do? It's going to go up. So then you're going to be at stroke level. And then you could potentially have a stroke. And so what we want to do is prevent that from ever happening. We want to prevent you, because if your blood pressure says high, we want to prevent you from having end-stage kidney disease where you're on dialysis. And then the decision becomes, do you stay on dialysis for the rest of your life? Or do you have a kidney transplant? Will you even be a candidate after a certain age to get a kidney transplant? And so I try to educate my patients about future complications of high blood pressure so that they're on board to take the blood pressure medicine and control it before it becomes an issue later on.
And it can affect your heart and your kidneys. That's what I tell patients. And they just, it's important to know it. I get so many patients who come to see me for a complication in pregnancy that has nothing to do with blood pressure. They have elevated blood pressure. I had it when I was pregnant. Did you have it outside? No. Did you go to a doctor and have it checked? No. So you have to go to have it checked because, as you're saying, you can't feel like you have high blood pressure, and it can affect your heart, your kidneys, and cause you long-term complications that you could possibly avoid with proper treatment.
Yeah, and I think it's important for young people to realize that it can happen to them. I think oftentimes the focus is on the older patient, the adult, the seniors who are having the strokes and, complications, but it starts early. And if you don't look for it, and I know that as pediatricians, we look, in children, and we can see hypertension in young kids, and it just then escalates throughout their life. So it's important for our young people to realize that they need to think about this early.
Absolutely. To speak on that, I have a literal 25-year-old who's now in end-stage kidney disease because he had diabetes type 1, but he also had high blood pressure that he did not control, and now his kidneys have failed. And so it's not just somebody 60 and older. You've got to be starting to think about this younger. Even if you think, oh, I'm fine, I'm young, I'll be fine, that doesn't necessarily mean you're going to be fine.
So pediatricians will check babies and children's blood pressure from 3. And that is a routine thing we do at your well visit. So it's very important that you have a pediatrician that you feel comfortable with, a pediatrician that listens to you, and the blood pressure will be taken every year. So once a year, it's important that you follow up with your doctor for your yearly visit. Also, we are checking blood pressure, cholesterol, sugar, usually at the age of 9 to 11. We've noticed that, especially in some cultures, these children come in, they've started to be obese, they've started to have signs of blood pressure increase. So having a routine every year for your blood pressure and starting to look at your cholesterol and your glucose as early as 9 to 11.
That's important to know. And one of the reasons I like that you, as pediatricians, take people up to the age of 21 because they don't often get in to see an OB-GYN doctor or an internal medicine doctor. There's a gap between my going in for my whatever 2-year shots and everything, and I'm taking my baby to the doctor, but then we're in this gap where maybe there aren't concerns. So if we can identify those are good. I'm going to go to Dr. Adair in a minute, but Dr. Dawson, I'd like to come back to you and talk about, so we identify high blood pressure. What are some things that we can do to reduce the blood pressure, whether it be medical treatment or other options of treatment there?
So I think the biggest thing that we've learned is that when your blood pressure gets to 130 over 80 or above, even if it's not at the threshold, we have to do something to help get your blood pressure down because you're headed in the wrong direction. And so one of the things we've always talked about is, hey, let's talk about diet and exercise. What does that look like for you? What does your diet look like? I always tell my patients when you go to the grocery store, try to stay outside the middle lines. So essentially fruits and vegetables, your meat department, milk and eggs, and leave. Try not to do all the processed foods because especially in America, we have so many processed foods with so much sodium in it that it's going to cause those blood pressures to go up. The other thing is, what are you doing for diet and exercise? How many steps are you getting a day? I'm not asking you to run a marathon. I just want you to get at least 7 to 10,000 steps a day. If you get 7 to 10,000 steps a day, that's technically active. And so I was like, what do you do on your lunch break? Why don't you take a walk for 30 minutes? You'll get those extra steps and you won't necessarily have to go to the gym because everybody doesn't like the gym. Mm-hmm. And so trying to make sure you're walking and getting those steps is super important, and watching your diet. I will go through with patients, like if you bring me a diet log, we'll go through it together. There's free apps that will literally do your diet for you and calculate your sodium and are you getting too much. And so I will recommend MyFitnessPal and some of those other apps that are free that you can put on your phone and just calculate what you are doing as well as your steps.
Thank you so much. And then Dr. Adair, we know that people sometimes present to an OB-GYN before they consider being pregnant, that hypertension and diabetes are concerns. What thoughts and what do you want to share on that?
So basically, again, it's like everything else. You need to establish care with an OBGYN that you feel comfortable with. The recommendations now are that young women aren't required to get a pap smear until 21, regardless of their sexual activity or not. However, there are many times that young women come to our office for contraception. And one of the risk factors for getting contraception is elevated blood pressure. So we can sometimes be first line for intercepting those situations where people are borderline hypertensive and can be referred to a primary care doctor for more intensive care. So as obstetricians and gynecologists, we have to be more cognizant of paying attention to those things that aren't really in our scope of practice, but really can impact the care of our patient.
You know, and I know that with all of us, anybody who goes to a doctor, it's important to feel comfortable with your doctor. Do you have any advice or thoughts on what it means to be comfortable with an OB-GYN doctor, what they should consider? What are you open to discussing with your patients? And
my perspective on my field of work is it's the most personal interaction you can have with your patient, and that sex in general is a subject that a lot of people don't feel comfortable with discussing. And you as a young female should feel comfortable enough to have those candid discussions with your OBGYN about every aspect of life. I mean, your sexual health, your issues with maybe domestic violence. We sometimes are the first line for those discussions also. Just general health concerns, things like that. So everybody isn't for everyone. And that is why the earlier you investigate who might be a good person for you to care for you, that might come from a family recommendation, friend recommendations, and go and try them out. Mm-hmm. It is like anything else. You don't always buy your first pair of shoes, right? You try on several pairs of shoes, and the one that fits the best is the one that you purchase. And your choice of your OBGYN should be kind of similar to that.
Excellent. So, and then we know that diabetes, hypertension, those are risk factors for complications of pregnancy, including preeclampsia. And we're going to talk about preeclampsia a little bit more, and how we manage it when we talk about pregnancy. But we're before pregnancy now, and somebody comes to you and they've been seeing you for a while. They want to know why they should keep their blood pressure and their diabetes under control. What effects might that have in pregnancy?
So as we've discussed earlier, anything that is going on before pregnancy can have a detrimental effect on your pregnancy. And the more that you're optimized prior to that, the better off you are in the pregnancy and afterwards. What people don't recognize is that, okay, I have a little bit of hypertension beforehand. I don't do what I'm supposed to do. I get pregnant, and then I end up with preeclampsia. People who have preeclampsia are at increased risk of some type of cardiovascular issue after pregnancy. So it's not something that is just going to affect you right then. It is long-term. There are long-term consequences to you not controlling your blood pressure, your diabetes. Gestational diabetes, the same thing. You have diabetes in pregnancy. The risk of you having diabetes type 2 after pregnancy is very, very high. Most people end up, and I'm one of those people, most people end up, I have preeclampsia and gestational diabetes. I don't have hypertension currently, but I am a type 2 diabetic currently.
Amen. And so as Dr. Dawson points out, attention to diet, attention to exercise, those are things that can help possibly reduce the risk for our long-term benefit. If you're going to get pregnant and have a baby, you want to be around to help take care of them. Well, Dr. Matory, there are risks that are associated with diabetes. One things I want to focus on now is it's important to have your blood sugar under good control before you become pregnant, because it can affect some structures in the baby. And you might not even realize you're pregnant at the time that, for example, that the baby's heart is forming and can have congenital birth defects, heart defects that can affect your baby. So what are some of the concerns associated with diabetes that as a neonatologist you might see in babies associated with women who are diabetic?
Yes. We see babies who are born to moms with diabetes have a myriad of anomalies, and it can range from affecting their growth, so that some of these babies are smaller than they should be for that particular gestation. Oftentimes they're larger. And if they're larger, that means that they could be a challenge for delivery. It means that they then will have blood sugar issues also, because if you think about it, they have been exposed in utero, and my colleagues will speak to this, to a high sugar level. And so their insulin has been pouring out as the fetus to try to address this. And then when that cord is cut, the baby is delivered, insulin is still pouring out. And so we oftentimes see low blood sugars in these babies. And if it's low, it can cause respiratory distress. It can cause tremors, shaking. It can cause seizures. And so it's something we monitor very closely for babies who are born to moms with diabetes. We know that that complication is there. Additionally, we see babies born to moms with diabetes having anomalies affecting the heart. And so instead of a normal heart in this beautiful newborn baby, there are complications that impact their ability to survive. They oftentimes are admitted to newborn intensive care units, can have surgery, because their hearts didn't form correctly as they should have in this exposed area, the fetus, as a fetus, to the high blood sugars and the high insulin. We see that sometimes these babies are affected, their spine is affected, and they end up with, again, anomalies that we can only attribute to the high blood sugars and the insulin that they were exposed to in utero. So it's not a simple situation for the baby, unfortunately. And it goes back to, our hope that moms are thinking about of course, thinking about their health, but also thinking about the impact on their baby in the long run once they are pregnant.
So I'd like to reflect on that for a little minute, because you talked about the heart developing. Well, in pregnancy, a lot of people think of it as 9 months. In obstetrics, we think of it as 40 weeks. The heart develops at 5 to 6 weeks gestation. Women that's just about the time you missed your last period. You don't even know you're pregnant. And that's why it's important to be under good control before you get pregnant. The better you are, the better you are. Then she mentioned something about challenges of a big baby. Dr. Adair, would you talk to us about challenges of a big baby?
So there is something called shoulder dystocia.
The most frightening thing in my mind in obstetrics, but go ahead.
So there are situations where the baby delivers, the head delivers, but the shoulders get impacted behind the symphysis.
Impacted, you mean stuck and can't come out? Yeah,
stuck.
My goodness.
And it is an obstetrical emergency and requires some skill, patience, prayer, definitely
Amen.
prayer.
Some prayer.
But there is a higher incidence in larger babies. So a baby that is considered 4,500 grams or greater, regardless of whether you're diabetic or not, we will offer the mom a primary C-section because the risks increase. What's different about diabetes in pregnancy is that the proportion of the bigness is different. So the whole baby may weigh 10 pounds, but the chest and abdomen can be the size of a 14-pounder. So that makes it even more difficult. And that disproportion is noted in people who have diabetes in pregnancy.
Right. And that's why the head can come out, but those big shoulders don't fit out. And as Dr. Matori suggested, there's all this blood sugar crossing the placenta, going to the baby. The baby revs up its insulin system and it uses it to make these big fat tissues and stuff. I describe it to people, they don't have these commercials anymore, but that Michelin baby, that's what big plump baby where, my goodness, I kid you not, the most frightening thing in obstetrics to me is a shoulder dystocia.
And what people don't understand is it can be detrimental to not only the baby, but also mom. The end result of a baby that is that large and difficult to get delivered can be death.
Can be death. I've had, not personally, but reports of spinal cord injuries and paralysis
Yes.
of the baby. And it's just horrifying when it happens.
Definitely.
And you have 5 minutes after that head delivers before and sort of our countdown to say, when are we going to start getting some detrimental effects related to decreased blood flow to the brain and other things. So it's scary, and we can possibly avoid it by controlling blood sugar before, during pregnancy, but also by recognizing we think this baby's on the bigger side, and your obstetrician is going to talk to you about having a C-section. Anything else anybody wants to add about before pregnancy that we might need to consider before we shift?
I would say mental health.
Okay.
Just making
Amen.
sure that people are supported. Again, as obstetricians, we may be the first line for domestic violence or depression. Just addressing those concerns. I know a lot of patients that I see or used to see in my office would say, I want to get pregnant, so I stopped all of my antidepressive meds. And that is not something that is essential to be pregnant.
Or maybe even safe,
Right.
for
Right.
pregnancy.
And so it is something that really definitely needs to be addressed, and something that people need to be paying attention to.
That's an excellent point. I was going to...
Yeah, you just talked about making sure that you stay on your medications, especially for depression and anxiety. And the big fear for most parents, if you read a lot of the internet, or you hear from family members, is that, can I breastfeed my baby with my medication? And that's where your doctor comes in and explains to you that there are a lot of these medications that are actually compatible with breast milk. So stopping it for the future breastfeeding is not a good reason for that, because the benefit of you staying on your medicine while you are pregnant probably outweighs the risk of a potential, am I going to be able to use this medicine or not? And a lot of physicians will switch medications they believe that are going to be detrimental to breastfeeding before you are considering that, so that you continue to have this particular chemical that is helping your anxiety and depression in your system.
And just like Dr. Lauren is saying, the better you are, the better you are. You're going to be a better parent if you are grounded, centered, and mentally healthy. And people who have anxiety and depression prior to pregnancy are at increased risk having it postpartum. So if we address these issues early in pregnancy or prior to pregnancy, make sure they're optimized on their medications, the risks of those complications decrease significantly.
And people should feel comfortable talking to their care providers or family or friends about mental health concerns. We all have them. I'm one of the most optimistic people I know, but there are times when, with everything that goes on in our culture and our society, that you can feel down, and there's no shame in getting help about that. The one thing, and you bring up a good point, of whatever medication you're on, you might have a seizure disorder. You might have a heart condition, and we stop the medication. You have a seizure, you drive into a truck, and kill yourself. We're not done you any good. We've not done your baby any good. And while there may be some increased concerns with those medications, we can address those. Your doctor can help address what is safest. We'll do ultrasounds. We'll have Dr. Matori people available to help address whatever concerns are there. But sometimes you need the medication. And oftentimes, as Dr. Ostentucken pointed out, they're compatible with pregnancy. Don't just automatically stop a drug because you realize you're pregnant. Talk to your doctor first, and then we'll do what's best for everybody. Okay. So we can shift gears now, unless somebody had another thought they wanted to bring up. Those were excellent points. Any thoughts you have here on mental health or?
Well, I'm actually in school.
Okay.
So I'm in school to become a psychiatric mental health nurse practitioner. The main reason I decided to go back was because many times when I go see new moms, they're having more mental health issues than breastfeeding things. So I knew that there was something else I could do to help these new moms. So, you know, a lot of times we don't think about like the support that we need behind when you have a baby. Like you really have to build your village before you have this baby, because you cannot raise a baby by yourself. Like you really do need people, your village, like, and it doesn't even have to be your family. Like it can literally be like a friend that you met, like maybe even a friend that's pregnant with you. Like you guys can be going through this together and really, you know, leaning on each other. So
indeed, that's great advice. And you know, I deliver babies, do this for a living. When I had my first baby, I was so ignorant, so non-knowledgeable about what it was like to take care of a newborn. And,
Absolutely.
That is so true.
And you, amen, that you need help and that you
I feel like you just don't know till you
don't
get
know.
the baby and you're like, ooh, I can't give you back. Like this forever?
And that's normal, and that may be okay. But we'll talk about that near the end too, with postpartum depression and other things. But yeah, it's normal. It's normal to feel overexhausted and other things with life in general. And so to reach out to friends, to have colleagues, to have people that have experienced what you have, or just to hold your hand, or just sit there and listen when they're just, you know, this is rough, girl. Yeah, it's rough having a baby. So yeah.
And there is a style of prenatal care now called centering, where there's a group of pregnant women who have limited support, who can support each other. So that's an option for moms who really don't have a basis for support outside of that group. So something to look forward to.
To walk through it, it's sort of, I sometimes describe some conditions like going through the haunted house. We don't know what's going to come up, but we just feel better when we're holding somebody's hand and we just deal with it. So it's a little bit scary, but we got somebody to go through it. They may not know any more than we do about it, but we're holding somebody's hand to go through. Okay, so we've talked all about reasons why the better you are, and why it's best to be in the best condition you can be before you get pregnant, and why there's lots of people and healthcare providers and friends and family that can help you do that. But get attention to that you want to get pregnant, and get better if you need to be, because the better you are, the better.
Thank you for listening in today. Weren't you inspired, encouraged, and uplifted? We hope so, because we're praying the best for you. Join us again next time for more betterment, because the better you are, the better you are.